Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, erlotinib versus gemcitabine plus cisplatin as neoadjuvant treatment for stage 3A and 2 EGFR mutant non-small cell lung cancer, emergent CTONG 1103, a randomized phase 2 study by John et al. My name is Tony Mok, and I am a professor of clinical oncology at the Chinese University of Hong Kong in the Prince of Wales Hospital in Hong Kong. My oncologic specialty is medical oncology. With the advent of molecular targeted therapy, patients harboring driver oncogenes may now survive longer and better than before. And EGFR mutation is the prime example of such achievement. However, evidence for cure of patients with metastatic EGFR mutation-positive lung cancer remains scanty. In contrast, it may be more reasonable to first attempt cure of patients with earlier stage of disease using molecular targeted therapy. CTONG 1103, published in this issue of Journal of Clinical Oncology, is the first randomized study comparing neo-adjuvant erlotinib with chemotherapy for patients with stage 3A EGFR mutation-positive lung cancer. CTONG 1103. The report that accompanied this podcast is not an easy study to conduct. Between December 2011 and December 2017, investigators from 17 centers across China managed to screen 386 patients with stage 3A non-small cell lung cancer and identified only 72, which is about 19%, eligible EGFR mutation-positive patients. They were randomized to receive either erlotinib 150 mg daily for 42 days or 2 cycles of chemotherapy using gemcitabine and cisplatin as neoadjuvant therapy. After neoadjuvant therapy, 73% of the erlotinib arm and 63% of the chemotherapy arm received curative surgery, including 2 patients in erlotinib arm who received pneumonectomy. The primary endpoint of this study is tumor response rate, which is 54.1% for erlotinib and 34.3% for chemotherapy. However, the ratio of 2.26 for tumor response rate was not statistically significant. 2 other important and impactful endpoints included major pathological response and progression-free survival. Major pathological response is defined as less than 10% of residual viable tumor cell, and it occurred only in 10.7% of patients who received the erlotinib and none with chemotherapy. But on the other hand, progression-free survival was significantly better with erlotinib arm, reporting median of 21.2 months and comparing with 11.4 months with chemotherapy arm. In reference to the primary endpoint of tumor response, we should conclude that CTONG 1103 is a negative study. John et al. Had reasonably estimated the sample size based on presumptive response rate of 70% in the erlotinib arm and 36% in the chemotherapy arm. The reported response rate at 54.1% with erlotinib in this study has significantly fallen short of the expected response rate of 70%, which was actually the widely accepted response rate in patients with stage 4 disease. The authors selected 2 over 42 days of neoadjuvant erlotinib in order to match the 2 cycles of neoadjuvant chemotherapy, While there's no biologic reason to explain the lower response rate in earlier stage disease, the shorter duration of treatment may contribute to the relatively lower response rate. The other important outcome is the major pathologic response of 10.7% with neoadjuvant erlotinib, which is supposed to be a surrogate for overall survival. Hammond et al. Were among the first group to suggest the predictive power of major pathological response for neoadjuvant chemotherapy for patients with early-stage lung cancer. The lower than expected major pathological response rate may be considered a surrogate indicator for overall survival, but it's more important to wait for the mature survival outcome. Now, a negative study can still be impactful. This study has established the feasibility of neoadjuvant EGFR TKI for patients with potentially resectable EGFR mutation-positive lung cancer. The first single-arm phase 2 study on the preoperative erlotinib published in 2009 in Journal of Clinical Oncology enrolled 36 patients, but only 6 harbored the activating mutation. Tumor response was observed in 4 patients, and all were positive for the mutation. Another single-arm study published in 2018 in the journal The Oncologist enrolled 19 patients with EGFR mutation-positive stage 3A non-small cell lung cancer and treated with neoadjuvant erlotinib for 56 days. Tumor response rate was 42.1% and resection rate was 68.4%. Only 5 of the 14 patients, which is 35.7%, with surgical resection had documented pathological downstaging from N2 to N0 or N1 disease. The median progression-free survival and overall survival was 11.2 and 51.6 months respectively. CTONG 1103 is the first and only randomized comparative study that confirmed the feasibility and efficacy of neoadjuvant EGFR TKI. Tumor response rate is higher than chemotherapy by 20%, although not statistically significant. But toxicity profile is better, which is established fact from multiple phase 3 study on advanced stage disease. The resection rate was similar between the two arms, but it's unclear how many of the enrolled patients had unresectable disease prior to the neoadjuvant therapy. Key objectives of the neoadjuvant therapy are to downstage tumor or nodal disease and to improve resectability. This randomized study may potentially document if erlotinib is more capable of converting unresectable stage 3A disease to being resectable. However, this data is not currently available. The authors of this current study have also reported improvement in progression-free survival, but we cannot conclude that the improvement is solely due to neoadjuvant chemotherapy. As per study protocol, patients from neoadjuvant EGFR TKI arm did receive 12 months of erlotinib as adjuvant therapy, while the chemotherapy arm received only 2 more cycles of similar treatment. Considering the duration of therapy, the adjuvant erlotinib may in fact contribute more to prolongation of progression-free survival than the neoadjuvant therapy. In 2017, in the journal Lancet Oncology, the same group of investigators have reported a randomized phase 3 study comparing adjuvant erlotinib with chemotherapy, and the median disease-free survival was 28.7 months and 18 months respectively. All patients enrolled in this study had resectable lung cancer, with over 60% having N2 disease. And the pay authors had concluded on the potential survival advantage of adjuvant EGFR TKI. Thus, the improvement in progression-free survival should be explained by both neoadjuvant and adjuvant erlotinib. In summary, CTONG 1103 is a negative study, but it has significant impact on management of stage 3A EGFR mutation-positive lung cancer. With high screening failure rate at 80%, it took the author 6 years to enroll 72 patients. This study will remain the only randomized study on this patient group for a long time. A similar large-scale phase 3 trial of this strategy will be unlikely. Clinicians are obligated to share and explain CTONG 1103 to patients with stage 3A EGFR mutation-positive lung cancer. For patients with resectable disease and presentation, the benefit of neoadjuvant EGFR TKI may be debatable. But for patients with unresectable stage 3A disease, neoadjuvant EGFR TKI may potentially downstage the disease status and facilitate resection. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.